And I will focus on the third point, borderline resectable pancreatic cancer. And I will read to you the consensus statements, and then we can discuss this. The International Study Group believes that advances in treatment, especially for patients with borderline resectable pancreatic cancer, requires progress on the following issues. Which objective criteria should be used to preoperatively identify patients with borderline resectable pancreatic cancer? And is there enough evidence for operative exploration and resection in the presence of mesenteric-portal access or arterial involvement? Is there enough evidence for neoadjuvant treatment regimens in this subgroup of patients? So this will connect to your talk. How should the pathological specimen be examined? And should the site of residual tumor be reported, and should the depth of vessel invasion be assessed if present? So which objective criteria should be used? The outmost pre-treatment diagnostics is, of course, a very good high resolution CT. And the study group was imposing on a specialized pancreatic protocol CT performed in the previous 4 weeks, and including all of the abdomen and pelvis. Multi-detector CT with high-resolution multiplanar reconstructions facilitates accurate stratification. I will come back later on to this. This was a strong recommendation. All cases, and this refers also to a radiologist, should be discussed and managed by a multidisciplinary team or board in high-volume centers. This refers to the situation which is often encountered, that a radiologist will tell the oncologist this tumor is not resectable. And mind you, the only one who decides which tumor is resectable or not is the surgeon, not the radiologist. So the third point was the study group supports the imaging-based NCCN criteria for borderline resectability in the case of venous mesenteric-portal access involvement up to the encasement, the total encasement of the superior mesenteric vein or portal vein confluence and even short segment occlusions and arterial involvement. This was a strong recommendation, although in this study there was a huge fight between the UK surgeons, the surgeons from the UK who have, let's say, a more fatalistic approach to these patients, and the continental surgeons in Europe, as I might say. So, clear-cut criteria for resectability are no involvement of the portal vein or superior mesenteric vein or the confluence, and the existence of clear fat planes separating the tumor from arterial vessels. Borderline resectable tumors are present if there are absent clear fat planes separating the tumor from arterial vessels. If technical options of reconstruction are given, venous involvement up to the encasement of the superior mesenteric vein or portal vein and even short segment occlusions are considered as borderline resectable. Abutment or even short segment encasement of the hepatic artery and abutment of the SMA. Local irresectability by this consensus statement is present if long segmental venous involvement is shown by imaging, and this means beyond the second contributory of the SMV without technical options for reconstruction. That's the reason I always ask my radiologist if the encasement is going below the confluence to the middle colic vein. If this middle colic vein is free, then the patient is considered as resectable, but with a major resection. And the second point, the second criterion for local resectability is a long segmental encasement reaching the origin of the celiac axis or superior mesenteric artery and the lack of technical options for reconstruction. This was also a matter of huge discussion. I agree with my colleagues from the UK that once the origin of the celiac axis from the aorta is encased by the tumor, then the probability to do an R0 resection is very low. But once the origin is free, then we would go ahead and do a multivisceral resection with an arterial reconstruction. This is obviously a philosophy which is not, let's say, very common in the UK. So, is there an indication for operative exploration and resection in the presence of mesenterical portal axis involvement? This means the venous axis. And based on the currently available evidence suggesting similar survival rates to those reported for patients undergoing a standard resection, there is clear evidence supporting straightforward operative exploration and resection in the presence of mesenterical portal axis involvement. This was a strong recommendation. However, I will show you later on that, let's say, the evidence level is relatively low. And of course, you have to consider that these were experts from all 5 continents, all over the world, all leaders in pancreatic surgery, all leaders of very big, high-volume centers, which were collected there in Lago di Garda. There is currently no evidence, this you will be surprised, there is currently no evidence for neoadjuvant treatment protocols in borderline resectable pancreatic cancer patients with isolated venous involvement if technical options of reconstructions are given. And after intraoperative evaluation of tumor extent, venous resection is indicated if complete tumor excision seems possible, although this may lead to greater overall intraoperative or postoperative morbidity rates. Professor Bockhorn then led a subgroup which tried to classify the type of venous resections. And as you see, this is the proposed IS-GPS classification of venous resection. Type 1 with a partial venous excision with direct closure. Type 2 with using a patch. This means you have to resect more of the circumference of the vessel. Type 3, a circumferential resection with primary anastomosis, and type 4 using a graft after a long segmental resection of this mesenterical portal axis. The ISGPS strongly suggests that these vascular resections should be limited to high-volume centers with experienced surgical and multidisciplinary teams. Now we come to the crucial point. I think this has to be considered as a routine involvement of the venous system. What about arterial involvement? And this was a fight going on for at least half a day. And in fact, we were not even able to reach a consensus. So we were, I have to congratulate Professor Bockhorn, because he had, with all his diplomatic skills, he finally got the UK surgeons at the table and said, okay, this is the consensus, which will be published in surgery.